Hey everyone, this is Rich Slama, and in today's 5-minute lecture series, we're going to be talking about anaphylactic shock. So let's go ahead and jump right into it. Anaphylaxis versus anaphylactoid. So when you think about these two definitions, what you really want to focus on is the IgE mediated versus non-IgE mediated. So anaphylaxis is IgE mediated, and anaphylactoid is not. So here is an anaphylactic reaction at its finest. You get an antigen that is somehow in the body that gets absorbed by a B cell, which subsequently, after exposure to that antigen, makes a plasma cell. The plasma cell makes IgE, which binds to a mast cell. And now that IgE molecule specific to that antigen is on the mast cell. So when this happens for the very first time, patients do not get an initial response, or they may have minimal symptoms, if any. But what happens when the antigen is exposed to the body for a second time, this entire pathway gets skipped. The antigen comes down here, it binds one of these IgEs that have been preformed, and then it cross-links on this mast cell, which leads to the release of histamine, which subsequently causes capillary leak and many of the symptoms of anaphylaxis. Now, in an anaphylactoid reaction, what you have, very simply put, is that there's an antigen. The antigen does not do really any of this, doesn't make any IgE whatsoever of some type. Common thing for this to be would be like vancomycin. Vancomycin comes in. Vancomycin somehow activates complement, or somehow through a different pathway activates these mast cells without binding IgE, and subsequently leads to histamine release. So that, in a nutshell, is the difference between the two. So, since these are both clinically indistinguishable, the symptoms of anaphylaxis most likely are going to include hives, and the most dangerous things are swelling of the tongue and swelling of the throat, wheezes, asthma-like symptoms. The most important thing and the reason that these are important to know is because the hives can be present in either a severe or very mild reaction. The swelling of the tongue and the throat are particularly what differentiates a mild allergic reaction from a severe reaction of anaphylaxis. So the most common things that we see, at least in the emergency department, are reactions to drugs, insect bites, food allergies. All of these things are very, very common, but remember that the treatment is roughly the same. When somebody does experience this, it's going to be sudden in onset, and most usually, the faster that the symptoms come on, and the more quickly the symptoms are progressing, the more worried that you get as an emergency medicine provider. So there is a spectrum of disease. You can have a very simple allergic reaction, which could just include a skin rash, all the way up to anaphylactic shock, where the patient has full-blown throat swelling, hypotension, and just, total altered mental status. And regardless of the cause, you always want to look for any exposure and remove that exposure if possible. Labs are not going to help you. Even chest x-rays, all that other stuff is not going to help you unless you're suspecting a secondary disease process. So the treatment for this, as with any sick patient, always ABCs: airway, breathing, circulation. Okay, and airway is the primary thing that you want to secure first, because if these patients lose their airway, they're very, very hard to get back. Always 2 large bore IVs, always a cardiac monitor, always pulse oximetry. And the absolute number one thing, and the most important thing for these patients if they're sick, is epinephrine. The second line treatments, corticosteroids, those only work within 48 hours, and although they do address the disease process, they address it nowhere near quickly enough. And the H1 blockers like Benadryl and the H2 blockers like Zantac, they do help alleviate some of the symptoms, but just remember that all they are really doing is covering up the symptoms. They're not really physically making anything better, which in contrast to epinephrine, it does. So So this is probably the most important thing that you need to know for this entire thing. Anybody with anaphylaxis gets 0.3 milligrams intramuscular, not subcutaneous, not IV, of epinephrine. Okay, 0.3 milligrams intramuscular. That can be repeated every 5 to 10 minutes for recurrence of symptoms. And really, if they're still having symptoms after a second dose of this, you want to get on top of making an IV epinephrine drip, because that's going to be much more titratable to the patient's symptoms, and it's going to be a much more direct route. All right, and here are all the doses of all the other medications that you can consider. I'm not going to go over them. And then really anybody with a severe reaction who you've given multiple doses of epinephrine, they need to be admitted. Patients who maybe receive 1 dose of epi and they've gotten all their other treatments, and they're looking much better within 4 to 6 hours, those patients can go home with return precautions, with an epinephrine pen, and with some corticosteroids at the very, very least. And that is about it. I hope you enjoyed the 5-minute lecture, and we'll see you next time.